So let's move forward. Please join me in welcoming Dr. Duru Shah ma'am on stage. Ma'am will be speaking on impaired endometrial receptivity in PCOS patients.
Chairpersons, ladies and gentlemen, my talk is on impaired endometrial receptivity in PCOS. And now we know that the key function for any embryo, the key function of the endometrium is to implant and nourish the embryo, and the endometrium does not allow the embryo to implant except in a very narrow window of implantation, which is about 4 to 5 days in the menstrual cycle. The embryo is always rejected until the endometrium is primed correctly by hormones. So the definition of endometrial receptivity is the state of endometrium which is ready for the embryo to implant. And it is basically these ovarian steroid hormones which act on these hormones or the receptors in the endometrium. They enhance the implantation of the embryo or they reject the embryo. So when you have endometrial receptivity impairment, if there's complete impairment, it is definitely leading to infertility or recurrent early pregnancy loss. And if there's partial impairment, then it leads to obstetric complications like an accreta, placenta accreta. It may be pregnancy-induced hypertension or preeclampsia. In PCOS women, what really happens is that there are imbalanced hormones, which are ovarian hormones, and there are also metabolic disorders which cause the dysregulated expression of gene clusters in the endometrium. So these abnormal hormones affect the genetic and molecular structure at the endometrial level, causing decreased endometrial receptivity. So if you look at the normal physiology of endometrial receptivity, the ovarian steroid hormones, if you look on the, I don't know if there's a pointer here, yeah. It's very difficult to point with this. Anyway, if you look at this side of the column, the steroid hormones, ovary releases estrogen. Estrogen acts on the endometrial steroid receptors, causes proliferative endometrium, and this is acted upon by the progesterone, which is also secreted by the corpus luteum in the ovary, and this progesterone is controlling a whole cascade of growth factors, cytokines, etc. And it works on the proliferative endometrium, you see the connection, and it causes the secretory endometrium. Now at this point in time, the embryo comes in, and at the window of opportunity, there is the acceptance or the rejection of the embryo based on the various factors like the gene expression, the morphology of the endometrium, the ultrastructural changes in the endometrium, and a normal hormonal pattern. So this is the normal physiology, what happens. Now with PCOS, we all have understood that it has caused oligoamenorrhea, because of which there's increased estrogen in circulation. There's no progesterone because there's no ovulation. There is hyperandrogenism, and there is polycystic ovarian morphology. Now also associated with this is the insulin resistance and obesity, which occurs in almost 54% of patients, and anovulation can be corrected with treatment. The patients may ovulate, but still we know that the pregnancy rates are a bit low. And this is what we want to find out, is what really is going on at the endometrial level. Why are we having this problem? Basically related to the hyperandrogenemia, the insulin resistance, obesity. Now if you look at this data of our own experience, this is a data of almost more than 1000 patients, where we have got a TSH value with more than 4.5, so 7.9% are hypothyroid. There are 41% insulin resistant, 13% hyperandrogenic, 72% have anovulatory cycles, 53% are obese, with 45% having central obesity, which means again that it's insulin resistance. So in short, there's so much of metabolic derangement in the patients when they come to us. Unless you test them, you'll never know who's got what problems, and hence it's important for you to make sure that these metabolic disorders are not present because they affect the endometrial receptivity. I'll show you one interesting case. One Mrs. MK, who was 38-year-old, married for 6 years with a primary infertility for 3 years. She had undergone 2 cycles of IVF in another clinic which were unsuccessful, and she saw me. Her BMI was 35. She was obese. Her waist circumference was 105 centimeters. Her ovarian volumes were 13 ml and 11 ml. She had an AFC of only 6 and 8, which was not really like a polycystic ovarian morphology, but because she had a high ovarian volume, we labeled her as a PCOS. But as we know, as a PCOS woman grows older, the number of follicles go on reducing. They may be higher than what it would be at that same age in a non-PCO patient, but definitely the quality of the eggs reduces by the age of 38 to 40. Just like a woman who's non-PCOS, just because this lady has more numbers does not mean that she'll have a higher pregnancy rate. But the ovarian volume takes time to settle down. It tends to remain high even as she grows older, and that is why you may find that in this lady the volume was high but the number of follicles were less. She was a phenotype A, means she had all the 3 parameters. With hypothyroidism, she had insulin resistance and obesity. If you see her FSH, LH, LH is high, E2 was high on day 2 or 3 of the cycle, AMH was 3 nanogram, which is quite high for a 38-year-old woman. Now the main problems we found here is, you see her fasting insulin was 20 and her post glucose insulin was 421, which was very high, with an HbA1c of 6.1%, free androgen index 14.8, TSH 5.1 and HOMA-IR 4.5. Now she had undergone these 2 IVF cycles with these readings because she had never done these readings before. She underwent lifestyle modification. We put her on metformin 500 3 times a day, controlled her thyroxine, got control with 12.5 daily, and we gave her flutamide, that's an anti-androgen, to get lower her free androgen index. After 3 months of treatment, her TSH was 3.89. From 5.1 she came down to 3.89. The dose was slightly increased. She lost some more weight and things started coming back to normal. After 6 months, she had lost only 6 kilos of weight whilst the treatment continued. In the 7th month, treated for infertility was initiated. First cycle letrozole given with monitoring and IUI. She missed a period, pregnancy positive, without doing any IVF. This is what I'm trying to say, is that everyone doesn't need IVF. We need to correct their hormones, correct all the imbalances, and then try. Now here, with the problem was probably at the endometrium level. See, she ovulated, everything was okay, but she was not conceiving. So obviously it's at the endometrial level that because of the imbalanced hormones, the embryo was not implanting. She was ovulating before, but she was not getting pregnant. But therefore we need to understand what's going on wrong at the endometrial level. And what you must understand is that at the endometrial level, because of the unopposed estrogen, there's less progesterone because she's chronic and ovulatory. She's got hyperinsulinemia, she's got hyperandrogenemia and increased androgens. But all this gives a result to an impaired endometrial receptivity. The receptivity is decreased because of these increased hormones. Now in women who have got PCOS, there's low progesterone. And as we say that normally there's increased aromatization of increased androgens in adipose tissue. So you have a lot of adipose tissue, there's a lot of estrogen being released from there, and there is increased aromatization of the androgens which are being, she's in a hyperandrogenic state. So everything is increasing the amount of estrogens in the body, which is also causing endometrial hyperplasia. There's hardly any progesterone coming in, low progesterone. There's imbalance between apoptosis and cell proliferation, and because of this there is increased intrauterine androgen exposure, and also there is this increased intrauterine androgen exposure is also affecting the endometrium, which is due to the high estrogen and the low progesterone which she is having. So this imbalance at the level of the endometrium is preventing implantation. And clinical data have shown that women with PCOS have a lower endovascular trophoblastic invasion due to the increased circulating androgen. Therefore, reduce the androgen and the receptivity will get better. Overexposure reduces to androgens, causes reduced endometrial receptivity, and there's a whole explanation for this, which is quite very what you call it, lab scientific. So I don't think you want to go into this, but I've made you aware that there is a reduced endometrial receptivity. Now in animal models, it's shown that when in monkeys, that when there is a prenatal exposure to testosterone in monkeys and sheep, there are impaired quality of oocytes, enlarged polyfollicular ovaries, hyperandrogenism, and ovarian androgen receptor upregulation. So the androgen receptors are increased in the ovaries of these animals when they've done these experiments. In human beings also is found that there is a dysfunction because of these increased androgen receptors. Because there is more androgen receptors, the endometrial alterations in those babies are also increased. The receptors in their endometrium, if it's a female child, is also increased, and therefore when that child is born, will also have a problem with the same situation which her mother has gone through. So androgens and endometrial receptibility, if you see what really happens to the receptors are high in the proliferative phase, in the early proliferative phase, and they are seen at a high level. But gradually, as the late proliferative comes in and at time of ovulation comes in, there is a gradual decrease in androgen receptors, so that the androgen does not act on the receiving endometrium. This decrease of androgen receptors correlates with the genes which are expressed in the endometrium, which favor endometrial receptivity and helps implantation. So what happens in a PCO patient, because of her high androgens, there's a increase in androgen receptors in the endometrium, which do not reduce during the late proliferative phase. They remain high, and when the receptors are high, there's more androgen acting on the endometrium, and therefore the embryo is not able to implant. The embryo can implant when the androgen levels in the endometrium reduce, and this is another reason why the patient is not conceiving. Now when it comes to insulin resistance, again the same story. There are so many factors which give rise to insulin resistance, we know that, and this is all based on in vitro studies, which has been seen as you see over here. With insulin resistance, we know there is hyperinsulinemia, because when sugar levels go up in the blood, the insulin is not able to reduce that sugar, and therefore because that insulin is not working well, the insulin levels keep going up in the blood, and that is called hyperinsulinemia. It is because of the insulin resistance, and that again affects energy metabolism, reduces the endometrial receptivity, giving rise to low implantation rates, low pregnancy rates, and gives rise to low stromal cell decidualization. Now when the decidualization is low, naturally the embryo will not implant. Now it has been shown that when you give metformin to these patients, it definitely improves the endometrial receptivity, and therefore women who have got insulin resistance, if you give them metformin, it will improve the pregnancy rates, because you're improving the endometrial receptivity by removing the insulin resistance at the endometrial level. Now here is a meta-analysis to prove this information. This meta-analysis was done to summarize the evidence on the use of metformin to improve endometrial receptivity in women with PCOS. This method used was a PRISMA protocol, which is used for comprehensive research. 62 studies including 6,571 patients were evaluated. Two groups they were grouped into. One was the metformin group and one was a non-metformin group. And the primary indicators how they were assessing was with endometrial thickness on ultrasound and endometrial artery resistance based on Doppler values. And the secondary indicators were of course whether the clinical pregnancy rates increased or the miscarriage rates decreased. Now if you look at this chart, it's a very big chart, but just look at the lines which are marked with red. If you see the endometrial thickness statistically significantly increased, the first line. The second line is endometrial artery resistance index definitely decreased. So you see the p values. All the p values will show you 0.002, 0.02, everything is statistically significant. Clinical pregnancy rate is definitely increasing 0.000 something 1. Then the miscarriage rate again 0.006. It's not very clear, is it? It's a little hazy, I feel. Anyway, so this is what it's trying to show, that statistical significance present with the use of metformin in assessing the endometrial receptivity. Now, when it comes to a combination of hyperandrogenemia, hyperinsulinemia, both together on the endometrium, again, keeping all this in mind, with hyperinsulinemia, we know that there is a decreased sex hormone binding globulin. When the sex hormone binding globulin decreases, there is more of free androgen in circulation, and therefore androgens are increased. There is decreased aromatization of the adipose tissue, and whatever is being estrogen is being aromatized. Therefore, again there is increased androgens. But also because of high androgens, the endometrium is also exposed to more estrogens. So there's a lot of imbalance of hormones, because of which there is a imbalance between the apoptosis and cell proliferation, and there's a problem with the expression of proteins at the molecular level. So one was the morphological level, where we see it on ultrasound, whatever we saw, the thickness and the resistance index. The second is the level at the molecular level, where the whole gene expression changes, and that is the two ways in which it works. Now coming to a third aspect, which is adiponectin. This is an insulin regulating molecule, and it regulates the glucose metabolism. In normal implantation, you find that there are increased adiponectin receptors found in the endometrium during the window of implantation, and the decidual cells, and also the embryo after implantation. So in short, these receptors are found in endometrium, they are found in the decidual cells, and they are also found in the endometrium after the embryo has implanted. So in short, it is the decidual endometrium also which is able to secrete adiponectin. So now this particular molecule is helping to regulate the glucose metabolism, and in PCO patients you will find that it is definitely lower, and that is the reason why there will be all these problems associated. So if we start doing adiponectin levels, probably we may find that there could be a problem with adiponectin, but really there's not much we can do. It's just a marker to show you that it's a marker of insulin resistance, for which we are using metformin, and today we learned that we can also use incretins. Now this adiponectin thing has been assessed in non-obese PCOS women versus obese women. Non-obese lean PCOS women versus just lean women. Now this review and meta-analysis found that the results were that 9 adipokines were listed in all. Significantly, these levels even in non-obese PCOS women are low. So it's not because of the obesity that the adiponectin values are low. It is because of the insulin resistance in these patients, because of which this level is low. So once you get these levels low in PCOS women, you know it is because of this that the endometrial receptivity is poor. There are many adipokines, out of which leptin is one of the adipokines, but the abnormal adipokine levels in PCOS may be due to increased androgens, and therefore we must correct the androgens also when we are treating a patient. So low adipokine levels may be a marker for insulin resistance. Now coming to obesity, where obesity is concerned, I think everyone knows a lot on it. The conclusion of this particular studies was there were about total 11,314 overweight and obese women checked out, and they found that weight reduction before attempting pregnancy in overweight or obese PCOS women may increase the pregnancy outcomes, with an odds ratio. When the women were about 25 kilogram plus, the odds ratio was 1.7, and when they were obese, odds ratio was 2.0. So in short, it may help. With the significant live birth rate, we are not sure. The odds ratio is 0.79, not really very much better, but definitely improvement of results are seen. Now markers of endometrial receptivity and obesity can be in the form of gene. When you do the molecular genetics of the endometrium, they have found that there are various expressions which you see, and therefore there is a significant decrease in free testosterone levels leading to better fertilization rates during IVF and success rates of IVF. This is because during the window of implantation, you find in normal patients everything is working well. You see the good markers of reception, that is based on the ERA test. So the ERA test is based on the genetic markers which you see, molecular genetic markers in the endometrium. So in short, if that is affected, then you are going to be, with PCO patients, if that is affected, then you will be avoiding IVF at that point of time. So if you can assess endometrial receptivity, there are no specific tests, and I mentioned earlier, you can use ultrasound, you can do hysteroscopy, you can do uterine natural killer cells, endometrial receptor array, which is ERA, you can do a hysteroscopy, and you will see varicose-like vessels and ring-time glandular openings, uterine natural killer cells. Again, this has not been found to be very helpful. So today we are basically depending on the ultrasound appearance, morphological appearance, and the vascularity of the endometrium, and we are also looking at the chronic infection in the endometrium, and we are looking for hysteroscopy if there are any adhesions or anything in the endometrium. So with ERA, it is classified as you do this, the genes are selected, we take an endometrial biopsy, send it to the lab, we are looking at whether the endometrium is pre-receptive, post-receptive or receptive. Based on that test, you can't do the embryo transfer in the same cycle. You have to presume that that's the same thing happening in the next cycle, and then you transfer the embryo. That's what people are doing. But honestly, I'm not really impressed with this test because it doesn't really help us. It's a very expensive test, but at the same time, the concerns, whatever studies have been done, are not very positive. So if you look at assessment of endometrial receptivity today, if you see what is really sensitive is endometrial thickness more than 7 millimeters is a receptive endometrium, less than 7 is less receptive, and the sensitivity is 99% with a specificity of 3%. Endometrial volume, if it is more than 2 ml, it's receptive, less than 2 ml is less receptive, sensitivity is 93%. Endometrial pattern, the triple line pattern is good and absence is not good, the sensitivity is 87%. Endometrial blood flow is presence of flow is good, absence of flow is not good, sensitivity is almost 100%. And as a matter of fact, in our clinic, we keep doing the endometrial flow. We also look at which zone it is reaching up to, and zone, when it goes right up to the subendometrium, is the best. And the question is that everybody doesn't do that, but here they are talking about sensitivity being 100%. If you get a definite, poor flow, then you know that this is a it's not going to work well. Endometrial contractions, if they are absent, is good. If they are present, it's not good. So in short, these are the various assessments which have been done by some studies, and today they have tried to do personalized embryo transfer by doing the ERA test, and this is a systematic review and meta-analysis done in April 22, and there they have found that the p-value is 0.49, and they are not very happy with the results. The conclusions of the study was that 1/3 of infertile women suffer from displaced window of implantation. It's a promising tool. Good prognosis patients may not benefit from ERA. So where you have good young patients and you're doing an IVF, they may not benefit. But then if you do a personalized, you don't do it for everyone, you do it for patients where you have got recurrent implantation failures, you have got a non-receptive ERA the first time, then you correct the problem, then do it, then it makes sense to do it, but don't do it as a routine for all patients. So here the treatment options for ovulation inductions in PCOS patient is given, and they've looked at what is the effect on the endometrium. So if you look at clomiphene citrate, which is being given to a patient, there is a reduced endometrial thickness. We all know that the endometrium doesn't grow well. There's a suppression of pinopods at the molecular level, and there's an endometrial receptivity which is impaired. Coming to letrozole increases the endometrial thickness, it increases the volume, increases the vascularization, it increases the concentration of integrin, and these are the factors which help with implantation. Then metformin, if you see, it increases the thickness, decreases the endometrial artery resistance, it increases the glut expression, and it also affects the various molecules seen at the molecular level, so it's beneficial. With gonadotrophins, if you use an agonist or an antagonist, they do have an adverse effect on the endometrial receptivity, and therefore this is seen in the molecular genetic display, and therefore we tend to do more of frozen cycles now. We freeze all the embryos, because when we have stimulated them, we find that because of all these hormones being used, which are desensitizing the pituitary, the agonist, the antagonist, etc., therefore we freeze the embryos, and then in the next cycle, when we have not stimulated, then we may transfer. So in short, we get better pregnancy rates with a thaw cycle, especially in PCO patients, because there is some amount of hyperstimulation which occurs in PCO patients, and there is a little bit of an imbalance in the hormones at the endometrial level. So in short, I'll conclude that PCOS is a common endocrine disorder leading to infertility, majority due to anovulation, but it is not the only cause. Abnormal levels of hormones and their receptors in the endometrium negatively affect endometrial receptivity. This abnormal atmosphere environment following these hormone deficiencies have a hostile effect on the window of implantation, making the microenvironment unfavorable for embryo implantation. And this defective endometrium can lead to infertility, recurrent implantation failure, and recurrent miscarriages. Correction of insulin resistance, hyperandrogenemia, obesity can assist in improving this receptivity before initiating fertility treatment in infertile PCOS women. There's a new modality coming up, very big way, is gut dysbiosis, but it's a chapter by itself. I have not included it here because we were talking about impaired endometrial receptivity, yes, but then if I go into gut dysbiosis, it would have been another 20-25 minutes, so I've excluded that just now, but that is another factor which we have to consider. So this is again, I was at the G20 meeting representing the health professionals there, and this is my advice to the government, that we have to reduce obesity right from the children level, because as I mentioned, intrauterine transmission of PCOS is happening through epigenetic changes of the genes. We must prevent obesity in children. We must encourage sports in schools. I said encourage 1 hour compulsory school activity, sport activity in schools, rather than letting the parents do it, because parents are focusing only on academics, and therefore introduce that 1 hour physical session in schools. And the second thing I have suggested is to avoid serving any unhealthy food in the school canteens and on birthdays of children who are celebrating with cakes and all kinds of stuff in schools, and therefore that has to be stopped. If it goes through the whole country, hopefully we should be able to reduce PCO to some extent in our country. And again, I would like to ask all of you, join the PCOS Society of India. We are doing quite a bit of work on PCOS. We need more people from more disciplines joining in, so that we can make a bigger group, do a lot of surveys, do a lot of research. That's what we are interested in. Thank you very much for your kind attention.
Thank you, ma'am, for such a wonderful